Okay. So today we're going to talk about nursing care of high-risk pregnancies due to pre-existing conditions. And so this can either be due to a condition and acquired conditions. So this can either be due to a condition that they had prior to pregnancy or a condition that they acquire in pregnancy. I want to be mindful that your book goes into a lot of information that we are not going to cover. So please, when you're reading your book and you're reviewing your information in the textbook, stick to the topics that we cover during this lecture. Okay, so the high-risk pregnancy. So high-risk pregnancy is really when there's a concurrent disorder or pregnancy-related complication or some kind of external factor that can jeopardize the health of the pregnant person, the fetus, or both. So first, let's go over pre-existing conditions. So like I said, your book is going to talk about a lot more conditions than what we are going to focus on. So when you're reviewing your textbook, I want you to stick to the conditions that we are focusing on. Okay. Diabetes. So when we talk about diabetes, we're talking about both type 1 and type 2 for our pre-existing. And then I will discuss this in this part of the lecture, even though it is a pregnancy-related complication. There is also gestational diabetes, which is diabetes that occurs in pregnancy. And because it just makes sense to, do all diabetes at once. So the prevalence of diabetes, pre-gestational, accounting for both type 1 and type 2, is about 1 to 2% of all pregnancies. And gestational diabetes, the diabetes that are first diagnosed in pregnancy, are about 6% of pregnancy. So much more often are you going to see gestational diabetes than pre-existing diabetes. And so really remember, the pathophysiology is resulting from defects in insulin secretion or insulin action. And so our classification system, our pre-gestational, our pre-existing diabetes, we have type 1 diabetes, which is typically low incident insulin production. And then we have type 2 diabetes, which we know has something to do with high insulin resistance. Both have A and B subtypes. An A subtype is without vascular complications. So it's diabetes without any kind of vascular comorbidities. And a B subtype is diabetes with a vascular complication. So thinking about valve disease of the heart, high blood pressure, retinopathy, nephropathy, those complications that come from the vessels. And then gestational diabetes, this is really like carbohydrate intolerance and insulin, glucose intolerance noted in that first in pregnancy. And so this has to do with hormones of pregnancy, which we'll talk about, but it can be linked later in life to type 2 diabetes. So we take this very seriously, and it can still have risks for both the pregnant person and the fetus. Class A1, these are people who are diet controlled. These are people who are diagnosed with diabetes in pregnancy, and they're able to control their diet and exercise, and they never need medications. Class A2, these are individuals diagnosed with diabetes in pregnancy who require medications. And typically we prefer insulin, but we do use some oral agents. Okay, so I like this graph, and I'm going to explain this graph because it really shows what happens in pregnancy. And so hopefully you can all see my mouse. So, and this is really just pregnancy in general, what happens, but I'll explain it in terms of the pre-existing and the gestational diabetic. So early in pregnancy, that first trimester, so here's a normal person, not pregnant. This is their insulin needs. These are their blood sugars here. So in a pre-existing diabetic, this is where they live. This is typically how much insulin they need at baseline. Then they get pregnant. So when they get pregnant, those insulin needs typically drop at first. Earlier in pregnancy, individuals tend to be more hypoglycemic. And that's typically because they're not feeling well, they're nauseous, they may not be eating, so their blood sugar levels are lower. So they typically need less insulin in the beginning of pregnancy than they do later on. In somebody who doesn't have diabetes, they may also have some hypoglycemia or lower blood sugar levels just because, again, same thing, they're not eating as well, they feel nauseous, maybe they're vomiting, so their blood sugar is a little bit lower. When we get into the second trimester, typically around like 20, 22, 23, 24 weeks, the placenta starts to kick in and the placenta releases HPL. And we've talked about HPL before. That's that human placental lactogen that causes insulin resistance. And this should sound familiar. We have talked about this. And so as that HPL kicks in and that a hormone that's causing insulin resistance kicks in, now all of a sudden their blood sugar is increasing and increasing and increasing and increasing and increasing because that HPL hormone is working against their insulin. So they're needing more and more and more insulin. So you can see if this was their primary insulin needs in a diabetic and they dropped and now all of a sudden they're going up and up and up and up. And this can be really scary for a diabetic, especially someone who maybe is really used to controlling their blood sugars prior to pregnancy, because all of a sudden they're needing more and more and more and more and more insulin. Typically in the third trimester, individuals could need 2, 3, 4 times the amount of insulin they needed prior to pregnancy to keep their blood sugars normal. It typically levels off at about 36 weeks or so, and it's going to stay there until delivery. So you'll see that plateau. After delivery, their blood sugar is going to drop rapidly in that first 24 hours. And the reason that blood sugar drops rapidly in that first 24 hours is because what's gone now? The placenta is gone. So the placenta is gone and there's no more of that HPL hormone being released. So that drops and then it'll typically level off. If somebody's breastfeeding, their insulin needs will stay a little bit lower while they're breastfeeding because they are giving some of the glucose that they're getting to the baby. And then once they stop breastfeeding, or if they're not breastfeeding, their blood sugar levels are going to pretty much normalize, and they're going to go back to their pre-pregnancy insulin needs at about 7 to 10 days postpartum. So I think that this is a really nice visual of what happens. And this is similar in someone who has gestational diabetes. Their blood sugar will also increase. And that's why we wait for gestational diabetes. We diagnose them and we test them around 24 to 28 weeks after that HPL hormone kicks in. And because they start to have that insulin resistance. And so very similar, this is a nice graph to help explain it. Okay, so our pre-gestational diabetics, when we're looking at just diabetes in pregnancy. So the first slide, we talked about diabetes in all pregnancies. Now, when we just account for 100% of pregnancies having diabetes, 13 to 21% of those have pre-gestational diabetes and the rest are gestational diabetes. So you'll see again that really gestational diabetes is the bulk of what we see. It's really important for these patients to have preconception counseling, and I'm going to come back to that in a minute. So what can happen to a pregnant person who gets pregnant who has pre-gestational diabetes? Well, one of the risks is they could have ketoacidosis, so DKA. So you should have learned about DKA in med-surg. And so typically in a normal adult, we worry about DKA at blood sugars of like 250 or above. But in pregnancy, we've actually seen DKA at blood sugars at 200, and in some cases, even slightly under 200. So that is still a complication that can happen in pregnancy. Polyhydramnios, so excess amniotic fluid. And so if you think about it, if somebody has high blood sugars, and that glucose can pass over to the baby because glucose is able to go over to the baby. And we've talked about this. And the baby has high blood sugars. It can be drinking and peeing, drinking and peeing, drinking and peeing. Because remember, that's how we make amniotic fluid. And so they can have increased extra amniotic fluid. The pregnant person can have hypo or hyperglycemia. It does put them at risk for gestational hypertension and preeclampsia, which are blood pressure conditions. It puts them at risk for infections, just like other diabetics. It can put them at risk for postpartum hemorrhage because they can have larger babies and polyhydramnios. And we know if their uterus is stretched out, it puts them at risk for postpartum hemorrhage. And it does have an increased risk of pregnant person mortality. Now, risk to the fetus, macrosomia. So that's a large baby. And we talked about this. Macrosomia is a baby over 4,000 grams. We consider that macrosomia. And so that's a larger baby, which can cause trauma to the birth tract. It can cause a stretched out uterus. It can put them at risk for postpartum hemorrhage. So all of those things can play in. Babies can have hypoglycemia at birth. So I know I talked about this a little bit, but I'm going to talk about it again. So in pregnancy, a pregnant person, their glucose levels are able, and their glucose is able to pass through the placenta. And so if their blood sugar is high, the baby is getting a lot of elevated glucose levels. And remember, we talked about babies have to make their own insulin in utero to account for those high blood sugar levels. A pregnant person's insulin their own insulin that they're making does not pass through to the placenta. So the baby's pancreas has to be making their own insulin in utero. So if a baby is used to a pregnant person having high levels of glucose the whole pregnancy, and their pancreas is having to make insulin and insulin and insulin and insulin throughout the pregnancy, as soon as they're born and that cord is clamped, something does not signal to the baby like, hey, your dessert bar of all that glucose that you had has been shut off. And their pancreas keeps making insulin, so it puts them at risk for hypoglycemia at birth. So it's really important that our diabetic patients have normal blood sugars in labor and in pregnancy so that the baby is not used to making all of this insulin, and it helps keep them at risk for hypoglycemia. Congenital anomalies. So in our pregnant patients, we actually worry about cardiac anomalies in the baby. And this is specific if their hemoglobin A1C is elevated at the time of conception. So it's really, really important that somebody who is diabetic has preconception counseling and is prepared to get pregnant. And we really want their A1C values, so that hemoglobin A1C that tells us what their blood sugar has been. We really, really want it to be ideally 6 or less prior to getting pregnant, because data shows us that when somebody has a hemoglobin A1C of 6 or less, the risk of congenital anomalies, specifically cardiac defects, are the same as in somebody who is not diabetic. Now, some diabetics are not able to tolerate blood sugars at a level to get their hemoglobin A1C to a 6. So data has showed that we are also okay with between 6 and 6.5. It's better at 6 or less, but between 6 and 6.5 is still also beneficial. Respiratory distress syndrome. So these babies sometimes have to be born early because of their blood sugar, or they're larger and we're delivering them potentially because they're larger, or the blood sugar is uncontrolled, or there's something going on with the baby. And that can put them at risk for respiratory distress syndrome because they can have a immature respiratory system. Stillbirth, they are at risk for that, especially in diabetics who are poorly controlled. We also worry about that in diabetics who have vascular issues. We worry about that. And then growth restriction. So the reason we worry about growth restriction is because thinking about our diabetics who have the vascular complications, so hypertension, other nephropathy, retinopathy, their vessels do not work as well. And so if they have vascular complications, remember the placenta has vessels feeding it oxygen and nutrients. And so if there's complications with their vasculature, inevitably there's going to be complications with the vasculature of the placenta. And if the vascular of the placenta is not working right, the baby's not going to be receiving the nutrients it needs, and it's going to be at risk for being smaller. Okay. So what are our treatment goals for our pre-existing diabetics in pregnancy? We really want to achieve and maintain normal levels. So we know that if a patient is at euglycemia, so a blood sugar between 65 to 120 the entire pregnancy, their risks in pregnancy and to the baby are essentially the same as a non-diabetic. It's also really important to identify and treat any complications associated with diabetes. So at the beginning of pregnancy, we're going through everything. We're screening them. We're taking care of any complications that we're seeing, so that it doesn't cause further complications down the road. So typically in our diabetics, routine screening that they're going to have either at their preconception or during pregnancy is we're going to monitor their hemoglobin A1C. We're going to check their kidney function tests to see how their kidneys are doing. We also typically will check their liver function tests because these individuals can be at risk for, we talked about preeclampsia and blood pressure issues, and we'll talk about that in a couple slides, but that also can have some liver function test changes. An eye exam is really important to make sure there's nothing going on with their eyes. A cardiovascular assessment, typically they'll get an EKG, and then thyroid function tests. And that is because typically you'll see that thyroid disease and diabetes go hand in hand. So if they have diabetes, they're at increased risk of having thyroid disease. So what are we doing for them in that antepartum period? So diet. Typically, you know, these people, especially if they're type 1 diabetic, they're used to really controlling their diet. But now they have all these changes in their insulin needs. So they may need to go back and see a nutritionist. Really, they want to be mindful. Typically, in somebody who's not obese, they're having about 30 calories per kilogram per day. In somebody who's obese, it's going to be closer to about 25 calories per kilogram per day. No more than 50% of their diet should be carbohydrates, but we absolutely can refer them to nutrition if necessary. Exercise is encouraged, and exercise actually increases the sensitivity to insulin and can help reduce blood glucose levels. It's really important in a diabetic that if they're going to exercise, they check their blood sugar before, during, and after, because it's going to drop their blood sugar levels. So they may need a snack before they go, especially thinking about in that first trimester where we talked about their blood sugar levels are lower than usual. They should definitely be checking their blood sugar before they exercise, having a snack, checking it during, and then checking it again after. So our type 1 diabetics and our pre-existing diabetics typically are used to checking their blood sugar, but they're used to different levels than what we want in pregnancy. So in pregnancy, we check their blood levels fasting, and then we check them after they eat. And the reason that we check them after they eat is because that is the spike that goes to the baby. So that after eating blood sugar is what we want to keep normal so that all this glucose is not going over to the baby. So instead of doing pre-prandial blood sugars, we do post-prandial blood sugars. Now, I will say in some diabetics, if they're having a really hard time controlling them, they may actually have them do pre and post-prandial blood sugars. But majority of the time, we're doing post-prandial, so after eating. Our goal with our diabetics is that their fasting blood sugar is 95 or less, okay? Postprandial, so that will depend on the provider. Some do 1 hour postprandial, some do 2 hour postprandial. I will say in my experience, most people do 2 hour postprandial, so that's doing a blood sugar 2 hours after they eat. But if they do a 1 hour postprandial, they want it less than 140. And if they do a 2 hour postprandial, they want it less than 120. Okay. And so depending on what their postprandial blood sugars are, what will happen is the provider will adjust their pre-meal insulin to get that postprandial blood sugar to where it needs to be. So we're still giving insulin before they eat, or they may still be on a continuous, insulin pump and be bolusing depending on what their provider has them on, but we really care about that postprandial blood sugar. A urine analysis. So at every visit, they're going to get a urine analysis. We want to be looking for ketones and glucose. If we have a patient who has a blood sugar over 200, they absolutely need to call their provider. And if they're experiencing hypoglycemia, typically that's like a blood sugar between usually like 63 to 70. They really should let their provider know. They're going to have frequent prenatal visits. So typically, they're going to have visits 1 to 2 times a week, potentially. Every 1 to 2 weeks in the first trimester, and then in the second and third, they're typically, depending on what their blood sugars are, they may be seen once a week or even twice a week in the third trimester. Because that's really close monitoring of their blood sugars and really close monitoring of their blood pressure. Now, sometimes they'll be able to have virtual visits, so they don't actually have to come in and they just talk about their blood sugars, but every provider is different. These patients will also have fetal surveillance. Remember back when we learned about NSTs and BPPs, these patients will have that because they do have a condition that could potentially affect the fetus. So depending on their diabetes and depending on how well controlled their blood sugars are, this may start at 32 weeks or 36 weeks. It may be once a week or twice a week. They're going to have growth ultrasounds every 4 weeks to see how big the baby is. And oftentimes they'll also do a fetal echo. So they'll actually do an echo on the fetus between 20 to 22 weeks to look for any cardiac anomalies like we talked about. And then the delivery date. So typically, we're going to induce them at no later than 39 weeks. If they have complications, it'll be before 39 weeks. Ideally, they can have a vaginal delivery, but if the baby is estimated to weigh over 4,500 grams, then that's going to be a conversation on whether vaginal versus C-section is the ideal because of complications that can occur, like complications like a shoulder dystocia, which is when the shoulder gets stuck, and we'll talk about that in a couple weeks, or potentially talking about, trauma to the genital tract like we learned about.
Say good morning to everybody in the world.
Oh, can we mute, please? Thank you. Okay, so what happens intrapartum when they're actually in labor? Well, these patients have really close monitoring when they're in labor. We're monitoring them for dehydration, we're monitoring them for hypoglycemia and hyperglycemia. These patients are going to be on IV fluids. Typically, they're going to be on a combination of, they might be on normal saline or LR, and then depending on what their blood sugar is, we may have to add dextrose to it. So it's a lot of oftentimes switching between IV fluids depending on what their blood sugar is. We don't want their blood sugar, especially if their blood sugar drops below 70, then we're going to typically add dextrose to it. Typically, they're going to have their blood sugar checked every 2 to 4 hours, depending on the hospital policy in that latent phase, so that early laboring phase. And then when they get into the active phase of labor, they're going to have their blood sugar checked every 1 hour. If they are being induced and they're allowed to eat, then we will maintain their normal blood sugar schedule and check their blood sugars as we normally would when somebody is eating. But once they're actually in labor, we are checking their blood sugars typically every 1 hour. We want their blood sugar to be between 90 and 110 in labor because that's going to help prevent hypoglycemia. They're going to be on continuous fetal monitoring. So this is somebody who's going to be monitored continuously. And then again, we talked about a possible cesarean delivery. Typically, that is going to be saved for complications that may need a cesarean delivery, or if it's a really large baby, or if something arises in labor. But we really do try for these patients to have vaginal deliveries. Postpartum. So remember that graph that we talked about. Immediately postpartum, when that placenta is out and it's no longer releasing that HPL, their blood sugar is going to significantly decrease because the placenta is gone now, and that was causing that insulin resistance. So typically, the next day, they're going to need a third to maybe a half of the insulin they had when they came in. If they're not able to eat yet, if they're not taking in a regular diet, they're still going to be on IV fluids. They still need a glucose source. And then in the hospital, endocrine is going to help manage these patients to get them on a regimen to go home on. Now, remember, we said if they're breastfeeding, their blood glucose levels are going to stay lower. And so they're still not going to be at their baseline dose. If they're not breastfeeding, they'll get back to their normal dose, typically about 7 to 10 days postpartum. These patients can have postpartum complications. They can have a postpartum hemorrhage. They can have preeclampsia. Now, we'll talk about preeclampsia. Preeclampsia is typically something that happens in pregnancy, but we do sometimes see it postpartum. And then we want to encourage breastfeeding. Breastfeeding is going to help decrease the amount of glucose in their circulation. They'll need less insulin. It helps with bonding, but they need to make sure that they're eating and drinking, that they're having a snack, because it is going to reduce their glucose levels. So they do need to make sure that they're eating, okay, if they're breastfeeding. Okay, any questions about pre-existing diabetes before I go on to gestational diabetes? Okay, we'll go on to gestational diabetes. So as you can see, gestational diabetes is 79 to 87% of diabetes in pregnancy. So this is majority of the diabetes that we're going to see. And so really this is insulin resistance, first documented in pregnancy. And again, that HPL hormone plays into this, but these patients are at risk for diabetes, specifically type 2 diabetes later in life. So this occurs in the second half of pregnancy. It does not occur until that HPL really ramps up. So what are our risk factors for type 2 diabetes? Someone who has a personal history of impaired glucose tolerance, anyone who has a baseline A1C of 5.7 or higher puts them at risk. A history of gestational diabetes puts them at risk for gestational diabetes again. A family history of diabetes. If they're older than 25, if they have a history of a baby with macrosomia and a prior pregnancy, because that could have potentially been an undiagnosed gestational diabetes. If they have a history of an unexplained loss, if they have a history of congenital anomalies that they weren't sure what caused it, multiples, and then those that are Latin, Native American, African American, South or East Asian, or Pacific Islander do tend to have a higher risk for gestational diabetes. Now, what are our risks? So these patients have very similar risks to our pre-existing diabetics. So they can also be at risk for gestational hypertension or preeclampsia. They can also be at risk for infections. They can also be at risk for babies with macrosomia, again, because it's high blood sugar. So those complications, polyhydramnios, like we talked about, type 2 diabetes later in life, like we talked about. Ketoacidosis, it is rare DKA in these patients, but it can happen. For the baby, hypoglycemia, just like we talked about, especially when that cord is clamped because they're used to the higher blood sugar levels. These babies are not smaller because these patients typically don't have the issues with their vessels because this is not a pre-existing issue. These babies are typically bigger, and then also stillbirth. So how do we diagnose gestational diabetes? So in all individuals who are not already diabetic, we do not need to do this test in somebody who we already know is diabetic. We don't want to give high doses of sugar to somebody who is pre-existingly diabetic. We know that they're diabetic. So we only do this in people who do not have a pre-existing diagnosis of diabetes. We initially start with a screening test. So everybody between 24 to 28 weeks of pregnancy who does not already have diabetics undergoes a 1-hour glucose challenge test or an oral glucose screen. And so what they do is they drink a drink. It's 50 grams of glucose. Anyone who's ever tried it, people say that it tastes like black orange soda. It's really sweet. They have 5 minutes to drink it. And then their blood sugar is checked 1 hour after drinking the drink. So typically what's going to happen is people are going to come in between 24 to 28 weeks. The provider is going to say, okay, we're going to do your glucose test today. Here's your drink. You have 5 minutes to drink it. Please tell me what time you finish it. And then we're going to draw your blood sugar 1 hour after. And it's not a finger stick. They actually draw serum blood glucose. And then they get the results. So there's no specific number that everybody in the world can agree on. Some providers use a cutoff if it's 130 or higher, then that is considered screening positive. Some people use 135 or higher. Some people use 140 or higher. So anywhere that's 130 or higher, they could potentially be screening positive. Most often people are using 140 or higher because the research shows that using a lower level does not necessarily find more diabetics. It just makes more people go for additional testing. So if anyone's blood glucose is 140 or higher, then they have to go for a diagnostic test. So the first part, that 50-gram glucose challenge test or oral glucose screen, is a screening test. It is not diagnostic, okay? Once they either pass or fail that, so if they're 129, they're great. If their provider's using 140, if they're 139, they're fine. But if they're over 140 or over 130 or over 135, whatever their provider is using, then they've screened positive and they need to have diagnostic testing. Now, I will say, if I am to ask you questions on this, I'm not going to trick you. I'm not going to make you guess what number I'm using. If I'm using a number, it'll be a number that is either above or below all of those. I'm not here to trick you, because there's not a set number that we use in the United States. So if somebody screens positive, they then go to that diagnostic testing. And so that diagnostic testing is a 3-hour test. Now, for the 3-hour test, they need to be NPO from midnight. So this is typically done in the morning, because we do not want a pregnant person going NPO all day. Most places may not even want them to have water. So what they'll do is they'll come in, they'll have a blood draw of a fasting blood glucose level. Then they'll be giving the same drink, but now it's 100 grams of glucose. And again, they have 5 minutes to drink it. And then they draw their blood sugar 1 hour, 2 hours, and 3 hours after they drink it. And they look at the 4 levels. And they're looking for 2 abnormals. If they have 2 or more abnormals, then they are diagnosed with gestational diabetes. If they have less than 2 abnormals, then they do not have gestational diabetes. And so our abnormals, if their fasting is 95 or higher, that is abnormal. If their 1 hour is 180 or higher, then that is abnormal. If their 2 hour is 155 or higher, then that is abnormal. And if their 3 hour is 140 or higher, then that is abnormal. These are the numbers that we use here in the United States. And these are the ones that I just said, the 95, 180, 155, 140. So if someone came in and they had a fasting of 100 and they had a 1 hour of 200, but their 2 and 3 hour were normal, because they had 2 abnormals, they would be diagnosed with gestational diabetes. If somebody came in and had a fasting of 96 and everything else was normal, they would not have gestational diabetes, because they only had 1 abnormal. And so again, the first part is the screening that everyone gets between 24 to 28 weeks. And then the second part is the diagnosis that only individuals get if they screen positive, okay? And they need to have 2 abnormals to be diagnosed with gestational diabetes. And again, we are never doing this on a diabetic, because they're already diabetic. We're not going to give them all this blood glucose or all this glucose to increase their blood glucose. Okay, so what do we do if somebody's diagnosed with gestational diabetes? So these people are going to go to counseling with, typically there's like a diabetes nurse and often a nutritionist. They're going to talk to them about their diet. Typically, they want their calories to be, depending on their BMI, between 15 to 35 calories per kilogram per day. And then they're going to teach them how to check their blood sugar levels. They should still be exercising. It's absolutely safe for them to exercise. They should be checking their blood sugar levels before and after. And they're going to check their blood sugar 4 times a day, a fasting and then postprandial with every meal, breakfast, lunch, and dinner. So same thing as our pre-existing diabetics. We want their fasting below 95. We want their postprandial 1 hour below 140 and 2 hour below 120. And it's the same thing. We care about the postprandial because that is what is going to the fetus, and that's what we want to control. And then depending on what those numbers are, if those are abnormal, they may have to start therapy. Typically what they'll do is they'll check in with their provider every week on what their blood sugar levels are. And if they ever get to a point where 20% of their blood sugars are above where they want them to be, then they're going to talk about putting them on some kind of medication management. Typically that is sub-Q insulin. We usually use like a fast acting versus a regular or an NPH. It really depends on what's going on. And these patients will also typically have some kind of fetal surveillance with NSTs or BPPs, and they typically start at 36 weeks. Sorry, all my dog's going to be barking. And these patients will also have fetal growth, will be assessed every 3 to 4 weeks. Okay, so intrapartum. These individuals typically are not going to require insulin. Our pre-existing diabetics typically are going to at some point require an insulin drip to keep those blood sugars where we want them. And that insulin drip is going to be titrated with their fluids and their dextrose, like we had talked about. But in our gestational diabetics, it's very rare that they need an insulin drip. It's not that it couldn't happen, but it's just not as often. We typically want their blood sugars between 70 and 110. If they need an insulin drip, it's going to be a regular insulin drip, just like in our pre-existing diabetics. And then same thing, these people are going to have C-sections if a complication arises. This is not a need for a C-section just because somebody has diabetes. Postpartum, so this is where it's a little bit different. Their blood sugars are going to return to normal, like we said. After that placenta is out, their blood sugars are going to drop. But these people did not have diabetes prior to pregnancy. So we don't need to check their blood sugar. They're not going to be on anything. Even if they were on a medication in pregnancy, it's going to be stopped after delivery, and that's it. We don't need to keep checking anything. Sometimes some providers will try to get a fasting blood glucose because if somebody has a fasting greater than 126, that is suspicious that they do have an underlying diabetes. But to be honest with you, in the postpartum period in the hospital, it's really hard to get a true fasting blood sugar because people are awake. They're feeding their babies or they're having a snack. And so it's really hard to get a true fasting. These patients are going to have a 2-hour glucose tolerance test. So similar to the one we talked about, that 3-hour for diagnosis, except it's 75 grams of glucose and it's 2 hours. So it's a fasting, a 1 hour and a 2 hour, and that will screen them for type 2 diabetes. And so they will have that at their 6-week postpartum visit, but otherwise they will not go home on anything. They will not have blood sugars typically in the hospital, and they won't need anything. Okay. Any questions on diabetes before I move on to the next topic? Okay. HIV and pregnancy. So this is really it's older data, but it's the most recent data that I can find from the CDC. So it's estimated that 19.2 million women were living with HIV in 2019. About 48% of the new cases in 2019 were women, and approximately 5,000 HIV positive women give birth in the United States annually. So as you know, we screen our individuals in the first trimester for HIV. That is a routine part of our prenatal care. And in some places, they may be screened again if they're high risk or depending on how prevalent it is in the community where they are. It may be part of the NICU protocol or nursery protocol that they're screening again. So our goal with HIV and pregnancy is to really limit the impact it's going to have on the baby. Pregnancy itself doesn't have a negative impact on HIV. And really our goal is working on prevention of passing it to the baby and keeping the pregnant person as healthy as possible. Okay, so, we know about vertical transmission. So our risk of transmission is 15 to 45% with no treatment and then 1 to 2% with treatment. So it's not totally absent, but it's significantly decreased with treatment. We know that transmission risk is higher in somebody who has a high viral load, so we really want them on their antiretroviral therapy. If they have prolonged rupture of membrane, so if their water is broken for a long time, which is why we really want these people ideally in and out in labor. We don't want to break their water. We want their water to break on its own because it puts them at higher risk for transmission. If they develop chorioamnionitis, an infection of the amniotic fluid, it puts them at risk for transmission. And if they're not adhering to their medication, it's going to put them at risk for transmission. So if somebody has a high viral load, so we define that as a viral load greater than 1,000, those people are going to be recommended for a C-section to help reduce the risk of transmission. So reducing the risk of their water being broken a long time, getting an infection because of vaginal exams. It's a quicker process. If somebody has a viral load under 1,000, and typically this is checked around 34 to 36 weeks. If it's under 1,000, then they can have a vaginal delivery. If it's over 1,000, then we're going to recommend a C-section. If somebody has not taken their medications or they started their prenatal care after 36 weeks, then we are going to recommend a C-section. But otherwise, they can have a vaginal birth. And really, transmission of HIV in pregnancy to the fetus has changed dramatically since we use antiretroviral therapy. So what are we doing for these patients? In the antepartum period, we're keeping their nutrition optimized. We're optimizing their immune function, keeping them from getting sick. We are monitoring them for infections. We are treating and testing for any STDs. They can be at higher risk for this. So if they have them, we're treating for them. HIV patients have different pap smear guidelines than our patients who do not have HIV. So we're making sure that they stay up to date with their pap smear guidelines. We're making sure that they're taking care of their medication. And so these patients are going to be co-managed with infectious disease and typically our maternal fetal medicine, which are our high-risk doctors. So making sure that they're taking their medicine. We want to provide emotional support for them and education and refer them as appropriate. And so intrapartum and postpartum, we don't want a fetal scalp electrode on the baby. We don't want to use an intrauterine pressure catheter. We don't want to rupture their membranes. We don't want to use forceps or a vacuum to help deliver the baby, because all of those things can be risk for trauma to the baby, risk for infection, and all of those things can potentially increase the risk of transmission. So we want to avoid that. Zidovenadine is a medication that we use depending on the patient and the method of delivery. We will use this to prevent transmission, and this is hospital policy and how they'll receive it in labor. We do give babies a newborn bath right away to help remove the secretions to help limit the risk of transmission. And then these patients are not going to breastfeed. So in the United States, we do not recommend breastfeeding in somebody who is HIV positive with their newborn, because it can increase the risk of transmission. We do have clean water. We do have formula available here. And we have resources to help people get formula if they need it, if they cannot afford it. And this is a CDC recommendation. Outside of the United States, in other countries where there may not be formula readily available or clean water, patients may breastfeed. The World Health Organization would recommend breastfeeding because the risk of the baby not getting fed versus transmission, if the pregnant person or now the postpartum person is on treatment, is a lower risk to the baby. So it is different here than it is in other countries. And so for us, a lot of our counseling is on what to anticipate immediately after. So that newborn bath, not breastfeeding, making sure they're still taking their medication, their baby will get a medication. And we'll talk about this when we talk about the high-risk newborn as well. Okay, so any questions about HIV or any questions about complications from prior to pregnancy? Okay, so let's talk about.
Hi, Professor. Sorry, I wanted to ask, if what's the nursing priority in gestational diabetes, and if we notice such, what should be the action? Should we report to the healthcare provider, or should we do anything?
Sorry, Ugo, I missed the first part of what you said. If what?
So I was asking, what is the nursing priority in gestational diabetes?
Yeah, so all of the things we talked about, counseling them, the nurses do all that. Counseling them on diet and exercise, counseling them on how to take their blood sugar, counseling them on what normal blood sugars are, when to call if their blood sugars are abnormal. If they're getting put on insulin or medications, the nurse is going to be counseling them on how to use that. The same thing. All those nursing roles is what's going to happen in gestational diabetes. So really, the nurse is not diagnosing them with gestational diabetes, but the nurse is going to know, oh, okay, their blood sugar is abnormal. They're going to have to come in for counseling on, they have 2 abnormals. They're going to have to come in for counseling. I'm going to meet with them. I'm going to counsel them on this. And in labor, the nurse is responsible for checking their blood sugar. If they need an insulin drip, managing the insulin drip, checking their blood sugars in labor. if they're having anything postpartum, checking it postpartum. So all those nursing interventions that you would do in med surg for a diabetic, you're doing here.
Okay, and secondly, what of can the pregnant person refuse a C-section? And if she does, what should be our teaching in such kind of situation?
Yeah, so they can, I mean, they can, yes. You cannot force someone to have a C-section that is refusing it. And as a nurse's role, that's not our job, but that is the provider's job to counsel them on the risks and benefits and to document that those have been explained thoroughly and that they understand the risks of not having a C-section.
Even when the baby is at risk of getting transmitted with HIV.
Absolutely. Yep. And you counsel that. To be honest, Hugo, most people, because this is explained to them so much in their pregnancy of this is what we're going to look for and this is what we're trying to prevent. It would be very rare for somebody to decline it, not to say that it can't happen. But that would be a conversation that you're having throughout the whole pregnancy, and you're documenting those conversations over and over and over again. And so if somebody has HIV, we're talking to them the whole pregnancy about, depending on what your viral load is, you may need to have a C-section. And oftentimes their infectious disease provider is talking to them, and their high risk provider and their OB provider. Everyone is talking to them about it, and everybody is documenting it.
Okay, sorry, the last question I wanted to ask. Okay, supposing the pregnant person gets hypoglycemic, should we
Yep.
still do the same intervention as from diabetes from med-surg?
So what, like giving them glucose?
Glucose or
Yes,
something that will bring it up.
yes, absolutely. They have to do something. We don't want it to stay low. Absolutely.
Okay, thank you.
You're welcome. Okay, let's move on to common pregnancy complications. So now these are things that can happen in pregnancy. So first, let's talk about bleeding during pregnancy. So when we talk about bleeding during pregnancy, we oftentimes can potentially divide it between trimesters. There is some overlapping. So for example, miscarriage can happen in the first trimester or the early second trimester. Ectopic pregnancy is only going to happen in the first trimester because we will have diagnosed it then. Second trimester and third trimester can sometimes have some things overlap as well. Preterm labor could potentially happen in the late second trimester. Placental abruption or placenta previa could happen in the late second trimester as well. So it's not cut and dry, but this is when they're most commonly happening. Okay, so miscarriage. So when we talk about miscarriage is a loss. And we use the word miscarriage, but there are different types of miscarriage, and there are different terminologies for the different types of miscarriage. So we're going to go through those. Now, I put implantation bleeding at the top and we've talked about this at the very first class. Implantation bleeding is light spotting with implantation. So this is, as the pregnancy implants into the uterus, the pregnant person has some light spotting. And we talked about it that sometimes they can confuse it for a period. And so this could be something that somebody does call about if they're trying to get pregnant and they notice a little bit of spotting. And so oftentimes it's trying to kind of troubleshoot, is this an implantation bleeding versus a miscarriage or what's going on? So I like to put that here just to have that conversation. Now, miscarriage. So we have, like I said, multiple different types of miscarriage. Now, I want to be really clear that before 20 weeks, the loss of a pregnancy is going to be, if it's not a termination, it is considered a miscarriage. If it's after 20 weeks, it is considered a fetal demise. And so this is why I say that miscarriage can kind of go into that second trimester, because remember, 20 weeks is in our second trimester. So miscarriage before 20 weeks, also, we will sometimes use the word abortion or spontaneous abortion. And then after 20 weeks, it's considered a fetal demise, okay? So a spontaneous abortion is a type of miscarriage that is a loss of pregnancy before 20 weeks. So this is on its own. So this is somebody who had bleeding and cramping and they had a loss. They passed the pregnancy, okay? So this is a loss of pregnancy before 20 weeks. It's a spontaneous abortion. A threatened abortion is when somebody has vaginal bleeding before 20 weeks and they're at risk for loss. So they've not lost the pregnancy. There is still a heartbeat, but it makes us suspicious that something could happen. So it's a threatened abortion. In these cases, they're typically, maybe they have a little bit of cramping, but their cervix is closed. We're not seeing any tissue on exam, but they are having some bleeding. And this is somebody that we're going to watch closely. This is a threatened abortion. An inevitable abortion, again, we're all of these are before 20 weeks, is when somebody has vaginal bleeding, and when you do an exam, we see that the os is dilated. So this is inevitable. Unfortunately, this person is going to have a loss of the pregnancy. There's nothing that we can do. We cannot give them a medication. We cannot do something to get their cervix to close. This pregnancy is going to, unfortunately, not be viable or survive. A complete abortion or complete miscarriage is when somebody has that loss and they've passed all the products of conception. So nothing is left inside. So this is after that loss. So somebody comes in with bleeding and cramping, and you check their ultrasound and there's nothing in the uterus. They've passed that pregnancy. Now, we typically we can't call an abortion or a miscarriage a complete miscarriage until they've actually gone through the process of passing the products of conception or passing the pregnancy. An incomplete abortion is when not all of the products are expelled. So something is still left inside, and this is requiring further management. So in these people, this is when maybe we did an ultrasound and the baby didn't have a heartbeat, and they were bleeding and cramping, and so they were miscarrying, and then they came back. They were still bleeding, or we were just doing a routine follow-up and we did an ultrasound and there's still something left inside. So they're going to require interventions to help their body expel the rest of the pregnancy. And then a missed abortion or a missed miscarriage is when somebody has no signs or symptoms. So typically this is going to be somebody who came in and maybe they already had an ultrasound. They know when their period is. Everything they feel fine, nothing, no bleeding, no pain, no cramping. And we go to do an ultrasound and there's no heartbeat and the pregnancy is measuring smaller than it was, or smaller than it should be based on their period. Now, sometimes early in pregnancy, it can be hard to decipher this and we need to do additional ultrasounds, but typically after, 6-7 weeks, we should be seeing a heartbeat. It should be measuring to size. So I always like to give the example. This is somebody who came in, by their very regular period. They should be 10 weeks pregnant. They go to have an ultrasound and the pregnancy is measuring 8 weeks with no heartbeat. That would be a missed abortion. Something did not signal to their body that they need to have bleeding and cramping. And so these people would need something to manage that. And so how do we diagnose miscarriages? Exam, we do a physical exam. We look, we see if there's bleeding. We look to see if the os is open, if we see tissue. And we also do an ultrasound. We can also do blood work, the beta HCG, the pregnancy hormone, to see if they're rising. Sometimes it's not a slam dunk that this is a miscarriage and we have to kind of figure out what's going on. And so sometimes, is this an early pregnancy? Is this a loss? Is it something that's just maybe their period dates are wrong? And so sometimes we do have to follow them with the pregnancy hormone, the beta HCG. So it's not always the answer right away that it's a miscarriage. And so this can be really stressful for people who have a desired pregnancy, and even those who had not had a planned pregnancy. It's a lot of stress to kind of figure out what is going on. Sometimes we know, sometimes we don't. So how do we treat them? So they can have expectant management. So they can let their body pass the pregnancy on their own. This does not come without risk. They can bleed heavily, unexpectedly. You know, it can just happen. There's no way to kind of plan for it. They can be at risk for infection. And if the body does not pass the tissue or all the tissue, then they may need additional interventions. We can do medications. And so typically medications, what we're going to do is we're going to give them misoprostol, Cytotec, to have their body have contractions to pass the products. And that is the benefit of that is they can take it in the privacy of their own home. They can be prepared because typically they're going to start passing the products a couple hours after taking the medication. And so it can be a little more controlled than expected management. And then dilation and curettage is when they actually go in through the cervix, they dilate the os, and they use tools to clean out the uterus. And so patients typically have an option of what they want to do, depending on what is happening. If somebody's body is passing the pregnancy on their own, then they don't need to use any of these management techniques. We typically give them warning signs and symptoms if they're having heavy bleeding, fevers, passing blood clots the size of a golf ball or a sudden gush of blood clots to let us know, saturating a pad in an hour or less to let us know. But if their body is not passing it on its own, then we need to talk about these methods. And that's typically going to be something that the provider is going to talk to them about, and the nurse is going to be there to support them. These patients will need, if they're Rh negative, they will need RhoGAM within 72 hours of the starting of bleeding. So as the nurse, you would be giving them the RhoGAM if they're Rh negative. Okay, ectopic pregnancy. So we've talked about this in the past. This is when implantation occurs outside of the uterus. And so risk factors, anything that compromises the tubes. So typically what happens is this is where the sperm and the egg meet and they fertilize and they actually implant most often into the tubes, but we've talked about this can occur anywhere. It can happen in the cervix, it could happen on the ovary, it could happen, there's been cases of it happening in a C-section scar, there's been cases of it happening in the intestine. And so anything that compromises the tubes and makes it harder for the egg to get into the uterus can put them at risk for an ectopic. Like I said, most often it happens in the tube. STIs, and that's because untreated STIs can cause scarring in the tubes, which can make it harder for an egg to move. And then an IUD. An IUD does not specifically cause an ectopic pregnancy. I want to be mindful that IUDs are very, very reliable. And that they overall limit the chance of pregnancy and reduce the risk of pregnancy. However, the hormone that is in there, progesterone, does slow things down. So it is potential that, and it does not inhibit ovulation, that if an egg and sperm were to meet, even with an IUD, it is because it does slow things down, they could potentially implant in the tube. The other thought is because an IUD is a T shape, you can follow my mouse here, and the T sits at the opening to where the fallopian tubes are, that potentially it could kind of like trap an egg in the fallopian tube and put them at higher risk. And so thinking about, anything that compromises the tubes, someone who had a history of tubal surgery before or something to their fallopian tubes is going to be at risk for an ectopic pregnancy. So symptoms of an ectopic pregnancy. These are people who have a positive pregnancy test and they have unilateral pelvic pain. So this is pelvic pain on one side. So it's not unusual for someone when they're first pregnant to maybe feel a little bit crampy as implantation occurs, but this is unilateral pelvic pain. Normal cramping pain is going to be mild and it's going to typically be in the middle. It is concerning if it's one-sided. They may have spotting. It could be, often it can be dark red or brown, but it could be pink. These patients can be totally asymptomatic, and this can be an incidental finding on ultrasound. If we're ever concerned and somebody has a positive pregnancy test and they come in and they're complaining of shoulder pain, this is very concerning because shoulder pain makes us think that potentially there was a ruptured ectopic pregnancy and that blood is in the peritoneal cavity, irritating the diaphragm, causing that referred shoulder pain. Much like after somebody has surgery and they have air in their abdomen and they can get that shoulder pain, blood can do the same thing. So if you ever have somebody that you're worried about an ectopic pregnancy on and they're coming or they're giving you symptoms of an ectopic pregnancy and now they're saying they have shoulder pain, that is very concerning. How do we diagnose it? We do beta HCG labs. So in a normal pregnancy, the HCG hormone will double every 48 hours. And in an ectopic pregnancy, it's not rising as expected. So it's rising much slower than we expect it to be, and it's not doubling. And on ultrasound, we are not going to see a pregnancy in the uterus. So we're going to take that together and we're going to be suspicious for an ectopic pregnancy. And their providers will diagnose that. So methotrexate, how do we treat it? We can give patients methotrexate. We think of methotrexate as a cancer drug. It inhibits cell division. This is a different dose than we would use if we were using it for like a cancer. And there's a protocol that we follow, and this is given specifically by nurses who are trained in giving this medication. The other option is surgery, where they either remove the ectopic pregnancy or potentially the whole tube, depending on what they're able to do. So what are we doing as nurses for these patients? We're monitoring to make sure that they're stable. We're getting an IV in and giving them IV fluids. We're giving them medications as prescribed. We're counseling them on, next steps. Sometimes in ectopic pregnancies, again, we don't know right away, and we kind of have to see what's going on. Some things may look like an ectopic pregnancy, and they're actually a normal pregnancy that's going to develop, or it ends up being a miscarriage. We need the pregnancy hormone to be at a certain level to be able to see it on ultrasound. And sometimes we're just not there yet. So we have to watch these patients really carefully. So we give them warning signs and symptoms: pain, bleeding, shoulder pain. You need to come to the hospital. Labs. If they're going to get methotrexate, they have specific labs that need to be done, and the nurse is going to do that. And then if these patients are Rh negative, they are going to need RhoGAM within 72 hours. Okay, molar pregnancy. So molar pregnancy, oftentimes we may not see this till the second trimester. There have been cases where you could potentially see it in the first trimester. This is an abnormal proliferation and degeneration of the trophoblastic villi. So the villi that make up the placenta, they cause these like grape-like clusters, and the embryo doesn't develop normally. The really concerning thing about molar pregnancy is it can turn into cancer. This is called trophoblastic disease, gestational trophoblastic disorder. And so our risk factors for somebody who has molar disease is someone who had a prior molar pregnancy, they can be at risk for it again. And someone who's in their early teens or over 40 tend to be at higher risk. And so how do we know if somebody has a molar pregnancy? These are people who are going to have excessive nausea and vomiting, like really, really bad, can't keep anything down. Their uterus is going to be growing much faster than anticipated. So this is somebody whose uterus is much bigger than what it should be for their gestational age. And so it becomes a question on, is their period not right and they're further along in pregnancy than we thought? Or is it multiples? Or is there a molar pregnancy going on? You're not going to hear a heartbeat in this situation, which is going to make you even more suspicious. They may have dark brown bleeding. Sometimes people will think it looks like prune juice. Like I said, no fetal heart rate. There are some forms of this where you could potentially hear a fetal heart rate, but in most cases you are not. And then on ultrasound, you see this snowstorm appearance. You don't typically see a pregnancy, you see a snowstorm appearance. See that, where it looks like snow is just falling everywhere? That's typically what's going to be seen on ultrasound. And so how do we diagnose this? Ultrasound and then beta HCG. These people are going to have a very, very, very high beta HCG. So typically early on, beta HCGs are a couple thousand, maybe a couple hundred, depending on how early it is. These people's HCG is going to be really high, like over 100,000 early on, which is abnormal. So that's going to make us suspicious along with the other things. Treatment. So treatment is going to be a dilation and curettage to clean out the uterus, like we talked about for the miscarriage. And these people need really close monitoring of their beta HCG. So this type of abnormal pregnancy, like I said, can turn into cancer. And the way that we know that it potentially is turning into cancer is the marker for this type of cancer is an elevated HCG level. And so we watch these patients really, really closely to make sure that their HCG level is not increasing. We used to watch them weekly for 3 weeks and then every month for 12 months. And we would tell them that they could not get pregnant for a year. These patients need to be on really, really, really good birth control so that they do not get pregnant. The reason they need to be on birth control is because if their HCG is rising, we need to figure out, is this because of their cancer? We don't want to have to potentially put a pregnancy in the mist and say, is this a pregnancy or is this cancer? So they need to be on good birth control. It used to be a year. Now, depending on the type of molar pregnancy they have, like I said, there's different types of molar pregnancy, which is more than you all need to know. It could be a year, it could be 3 months, it could be 6 months. That's changing. But what's important to know is they need close monitoring of their beta HCG, and they cannot get pregnant until their provider clears them. And so they need to be on birth control, and that this can turn into a cancer, so they have to be monitored. These patients are at higher risk of having a molar pregnancy again in their next pregnancy. So once they get pregnant again, they do need to see their provider right away so we can start early management and assessment. And if they are Rh negative, they do need RhoGAM. Okay, second trimester bleeding. So premature cervical dilation. So this is a cervix that starts to dilate prematurely. And what we worry about is the fetus, they may not actually be able to carry the fetus to term. Typically in these patients, they are going to be asymptomatic. They're not going to be having pain. They're not going to be having cramping. They may have some pink discharge. They may feel a little pelvic pressure. Risk factors, someone who had a prior preterm delivery or a prior procedure to their cervix, because it can weaken their cervix. Treatment. So how do we treat this? If it's caught early, potentially they can put in a cerclage, which is what you see here. And a cerclage is a stitch in the cervix that they then pull and they pull and they knot in place. And it essentially, think of like a drawstring bag, it pulls that cervix closed. To help prevent the cervix from dilating. The other thing that they can use is a pessary, which you can see here. I like to think of it as a little lounge chair for the uterus. What it does is it holds the uterus up so that the pressure is not on the cervix to help prevent any further dilation. Now, sometimes we will catch this because somebody comes in and they're saying they're having a little pink discharge, and we go to do an exam and we're seeing that their cervix is looking like it's dilating or feeling shorter. Sometimes we actually catch this on ultrasound. Everybody at their 28-week ultrasound has a look at their cervix. The ultrasonographer looks at their cervix to make sure it looks closed and it looks the normal length. And so sometimes we catch this on ultrasound as well. Okay, third trimester. So like I said, this can potentially happen in the second trimester as well, but we really mostly think of it as a third trimester complication. So placenta previa. So placenta previa is when the placenta is implanted low in the uterus. And so this means that it's too close to the cervix. And so, or sitting over the cervix. And we don't want the placenta to be too close to the cervix at the time of delivery, because we would not want the placenta to deliver first. That's going to cause bleeding. It's going to cause complications with the baby. And so we need the placenta in a normal pregnancy to be more than 2 centimeters away from the cervix, from the os, that opening of the cervix. And when it's not, we have something called a placenta previa. And so we have, different words for placenta previa, and I'm going to go over both of them. A marginal placenta previa, or a low-lying placenta, is when it doesn't cover the os, but that placenta is less than 2 centimeters away from the os. And so it's that low-lying, it's too close still. Partially is when it partially covers the os. So here you'll see a low-lying, so it's near it, but it's not covering it. B, you'll see it's partially covering the os, but it's not totally covering the os. And then C is a complete or total previa, when that placenta is just sitting over the os. And so typically what's going to happen in these cases is these patients may have painless, bright red bleeding. Risk factors for placenta previa are a prior placenta previa, uterine scarring, so a scar in their uterus. Our most common scar in our uterus is a C-section. So somebody who had a C-section, they're at higher risk for a placenta previa. We talked about before that the placenta likes to implant in that area where the scar is. So placenta previa, it's not growing through the scar like we talked about, but it's near the scar, and those scars tend to be low in the uterus near the cervix. Someone over 35 and a smoker. So symptoms: painless bleeding, non-tender uterus. And when I say painless bleeding, I don't mean the pain is in the vagina. I mean, they have no abdominal pain. They feel fine. They're not contracting. They feel fine. All of a sudden they had bleeding. And so how do we find this? So we find this a couple ways. Sometimes it's incidentally found on an ultrasound when they're having their 20-week ultrasound. It's just they happen to find that they have a low-lying or placenta previa, and we watch them. Sometimes we find this because they come in and they're bleeding, and we do an ultrasound and we find that they have a placenta previa. And so in somebody who comes in who is bleeding and we do not know where their placenta is, meaning we do not have a piece of paper telling us they do not have a placenta previa recently, like a 20-week ultrasound telling us they do not have a placenta previa, we are not sticking our hands in their vagina. And us as nurses, we are not letting anybody stick their hands in the vagina. We are the guardians, okay? The guardians of the vagina. We are not letting anyone do a vaginal exam until we know where the placenta is. And so if we have somebody who had a 20-week ultrasound that said, hey, they have a placenta previa, we know where the placenta is. So we think, hey, this is probably because of their placenta previa. We're definitely not going to do an exam. We're going to get another ultrasound and figure out what's going on. In somebody who we don't have an ultrasound on, or they haven't had a 20-week ultrasound yet, or they haven't had care with us, we are not doing a vaginal exam. We are getting an ultrasound to find out where their placenta is. Now, somebody who did not have a placenta previa after 20 week, at their 20-week ultrasound, and we wait till 20 weeks because we really need to know where the placenta is implanting. Before that, it's a little too early. Someone who did not have a placenta previa is not suddenly going to have a placenta previa. The placenta is not going to fall backwards. Somebody who previously had a placenta previa, it could potentially resolve. Now, as the uterus grows, if this is our uterus, as it grows and gets bigger, the placenta does shift a little bit with it. It doesn't detach, but as it grows, the placenta moves because the uterus is growing. And so it is possible for a placenta previa to resolve, but we can't assume that. We still need to get an ultrasound to check. We're not sticking our hands in there thinking, hey, their placenta previa must have resolved, their uterus is bigger. We still need to check. And if it does not resolve, by the time that they deliver, they're going to have a C-section because we do not want their placenta to be delivered first. And the reason we don't want to do a vaginal exam is because we don't want to potentially stick our fingers through a placenta. I know I don't want to be the person to stick my fingers through a placenta and cause massive hemorrhaging. And so what do we do with these people? We monitor them. They typically stay in the hospital for a little bit. Pelvic rest, nothing in the vagina, no heavy lifting, no intercourse, no tampons, nothing. We want to keep their pelvis really quiet, and then possible C-section if it doesn't resolve. If it's a low-lying placenta, typically those will resolve. The complete previas where they're sitting right over, or the total previas where they're sitting right over the os, those typically don't resolve and they're going to have a C-section. The incomplete partial, it really depends. It depends. I can't predict. And these people, if they come in bleeding, we will give them RhoGAM just because of the risk, if they're Rh negative, just because of the risk if maternal and fetal blood does happen to mix. It's better safe than sorry. So placental abruption. So placental abruption, placenta previa sound very similar. People sometimes get these confused. So it's really important to kind of think about the key differences. So placental abruption is premature separation of the placenta from the uterus. So remember, the placenta separates from the uterus after delivery, but this is happening before delivery while somebody is still pregnant. So in these cases, especially in severe abruption where it's ripping, the whole placenta kind of tears off the uterus, they can bleed very heavily and they can go into DIC. And we talked about this being one of the causes of DIC last week. So what are our risk factors for placental abruption? Hypertension, abdominal trauma. So someone kicking, hitting, punching, car accident, something that hits the abdomen. Cocaine abuse, and I've actually seen this, somebody using cocaine and then having a severe abruption. Prior abruption puts them at risk. Smoking puts them at risk. Premature rupture of membranes puts them at risk, and multiple gestation puts them at risk. So what is the difference here? Now, remember we talked about placenta previa, it's painless vaginal bleeding. In these patients, they're going to have painful vaginal bleeding. So again, it's not going to be pain in the vagina, it's going to be pain in the abdomen. They're going to have severe abdominal pain, they're going to have tightening, they're going to be tender when you touch their abdomen. When you look at the fetal monitor, when you put them on the fetal monitor, you're going to see a lot of contractions going and going and going and going. And on exam, like I said, they're going to have a firm, tender, rigid abdomen. We may see fetal distress, and if it's severe, we could see signs and symptoms of shock. So depending on how big this abruption is, this could be an emergency. So we're going to call for help. They're going to, again, we are not sticking our hands in somebody where we do not know where their placenta is. So if they've not had a recent ultrasound, we are not sticking our hands in their vagina to see what's going on. And we're going to get an ultrasound to see what's happening. And so we're going to monitor these people. Again, depending on how severe the abruption is, really depends on what the provider is going to do. They are going to have labs. We're going to get a CBC on them. We're going to check their PT, PTT, and fibrinogen because we said they could potentially go into DIC, and that's going to be a marker for that. The Klein-Hauer-Becky is a test that we use to help detect the amount of fetal cells in the maternal blood, because if we have a placental abruption, oftentimes there is that maternal fetal blood mixing, because that can happen during delivery. And this is something that typically happens, during delivery, the placenta comes off and now it's happening early. And what that test does is it tells us how much RhoGAM to give somebody. And sometimes we need to give people multiple vials of RhoGAM. We're going to get a type and screen because if this is severe, these people may need multiple blood products, and then delivery if this is a severe abruption. There are cases where people can have small little abruptions that kind of seal off, and they do well and the baby's fine and they just monitor them. But that is the provider's decision. So for the nurse is going to monitor the patient, their vital signs, they're going to monitor the fetus. If the plan is for delivery, it's going to be a C-section, and the nurse is going to prepare the patient, getting the IVs and the IV fluids in. If we're giving blood, the nurse is going to get blood. We're monitoring their vital signs, we're monitoring their hemodynamics, their fluid output, their urine output, and making sure, if it's severe, we're giving them oxygen to make sure that the baby's being perfused. So we're using that non-rebreather at typically 10 liters. And again, RhoGAM. Preterm labor. So this is labor that occurs before 37 weeks. So this is anywhere from 20 to 36 and 6/7 weeks. Because before that, we do not have preterm labor. It would be a miscarriage. So what are our risk factors for preterm labor? Infections. And when I say infections, I mean urinary tract infection, vaginal infection, STIs, potentially an amniotic fluid infection. Risk for polyhydramnios can put somebody at risk for preterm labor just because the weight of all the fluid can put pressure on the cervix. Smoking, substance abuse, hypertension, diabetes, history of preterm labor. So what are our signs and symptoms of preterm labor? They can be non-specific. They may have a backache, but it's a coming and going backache. It's not typically a constant one. It's something coming and going. They may have period cramps. They may feel pelvic pressure. They may have increased vaginal discharge, urinary frequency. Sometimes they may feel kind of like a little abdominal discomfort, nausea. So how do we diagnose it? A vaginal exam, the provider is going to do a vaginal exam to see if their cervix is changing. So what do we do for these patients? Depending on what their vaginal exam says, they could be contracting and their cervix is not dilating. So the nurse is going to give them hydration. They may need IV fluids to see if we can relax the uterus. If the uterus is if they're dehydrated, that uterus is a big muscle and it can contract and kind of become crampy. And so sometimes hydration can help this. The other thing that we can potentially do for diagnosis is something called a fetal fibronectin or an FFN. Now, this is a swab that is pretty expensive and not everybody has it. But what it is it's a swab that the provider can put into the vagina, and they send it off to the lab. And what the lab is looking for is these fetal fibronectins, which are proteins that act like a glue to keep this amniotic fluid sac kind of adhered to the uterus. And that glue starts to release around 35 weeks. And we shouldn't find these proteins in the vagina before 35 weeks because that glue should be intact. And so if there's preterm labor, that glue is not going to be intact, and we can potentially find those proteins in the vaginal secretions. Now, like I said, it's expensive. Not everywhere has it. So this may not be a test that everybody can do. The other thing is it's really good when it's negative. If it's a negative test, that's good to us. That tells us like, hey, it's very unlikely that this person's going to go into preterm labor in the next 2 weeks. When it's positive, it's really not that great for us. It doesn't really tell us much. It makes us suspicious that something could happen, but it does not mean somebody is going to go into labor in the next 2 weeks. Other things that we do when somebody comes into preterm labor, the provider is going to do STI cultures to rule out any infection. They're going to do vaginal cultures to rule out any like yeast or bacterial vaginosis, infections that are not STIs. We're typically going to do a CBC to see what their white blood cell count is. We're going to do a UA and a urine culture to make sure they don't have a UTI. And then if they don't have that group beta strep swab that we talked about that we normally do between 36 and 37 weeks, we're going to do that. So we have the results should they go into labor. So what do we do if somebody is in preterm labor? Can we stop it? We try to stop it. If somebody is before 34 weeks, we will try to stop the preterm labor. If they are 34 weeks and above, we typically will not try to stop the preterm labor because data shows that these babies tend to do well in the outside world. And so we should not try to stop the labor. It's not ideal, but the benefit is not there trying to stop the labor. So what medications can we use to potentially stop somebody's labor? The most common medication that we use is magnesium. Magnesium sulfate, we've talked about it. It relaxes smooth muscle. It helps to inhibit uterine activity. We give this, like I said, up until 33 and 6-7 weeks. Typically, it's a 4 to 6 gram bolus, and then they get 2 grams an hour. And they'll continue on that typically for 48 hours. And I'll explain why it's 48 hours in a minute. Nifedipine, so we can use nifedipine. This suppresses contractions by inhibiting calcium from entering smooth muscle, and it causes relaxation. Again, we can give this up to 33 and 6-7 weeks. We would not give nifedipine and magnesium together. It can very dangerously lower the blood pressure. And then indomethacin, what this does is it suppresses prostaglandins, and prostaglandins cause contraction. So by suppressing prostaglandins, it can suppress contractions. We do not use this after 32 weeks because this can cause premature closure of the ductus arteriosus. It's an NSAID, so we do not use this after 32 weeks. So if somebody is, below 32 weeks, all of these medications are a possibility. And again, we do them all for 48 hours. The reason that we do them for 48 hours is because we want to get enough time to give them betamethasone, which you can see here. Betamethasone is a steroid to help with fetal lung maturity. So it's a medication that we give IM every 24 hours for 2 doses, and it helps to establish fetal lung maturity so that if these babies are to deliver early, it's going to help them with breathing. It's a steroid to assist with surfactant production, which helps prevent alveolar collapse. And so typically if somebody is being diagnosed, what we'll do is we'll start their medication for the tocolysis, which is tocolytics are medications that stop contractions. They'll get one of their medications and then they'll get their steroid injection. They'll get 1 shot, it's 12 milligrams. 24 hours later, they'll get a second shot, which is another 12 milligrams. 24 hours after that, they are considered steroid complete. They have the benefits of the steroid. We will stop the tocolytic medication, and hopefully we'll have stopped that preterm labor. But if not, they now have the steroids for the baby's lungs if they need them. Antibiotics, in a preterm patient, I told you we will do a GBS swab, but while we don't have the results, we will give them antibiotics to prevent or to treat any GBS because those babies are premature. And again, they have premature immune systems. And then we're going to monitor the clients for their well-being, specifically if they are on magnesium. We will talk about magnesium monitoring in a couple slides, and it'll refer to our patients who are getting it for preterm labor and our patients who are getting it for preeclampsia. So please put, refer to magnesium slide. And so as a nurse, if you have a patient who's in preterm labor, you can anticipate the doctor is going to be giving one of these medications depending on their gestational age and the steroids. So being mindful, this is what you're preparing for. Okay, the doctor could give this or this or this and a steroid. So you're thinking about that. You're not making the decision of what the provider is going to give, but you're thinking about what the provider could be giving. Okay, preterm premature rupture of membranes. This is when water breaks before 37 weeks, but after 20 weeks. Risk factors, infection, just like we talked about, STIs, vaginal infections, UTIs, infection in the amniotic fluid, all of those things are possible infections that could cause this. And then history of prior preterm birth. Symptoms, so this is typically going to be a gush or a trickle of fluid. So how do we diagnose it? So in somebody who we're worried about their water being broken, we're going to do a sterile speculum exam. So we're actually going to use a speculum that is sterile and has been sterilized and is packaged. We're going to use sterile gloves. When somebody's water is broken, everything switches to sterile, even in labor. Before that, we do not need to use sterile gloves. We can just use normal clean gloves. So we do a sterile speculum exam, and on that exam, and sometimes nurses will do this, it depends on where you work. On that exam, you are looking for pooling of fluid sitting in the back of the vagina. You'll typically see it in the speculum blade. You then take out the speculum, and with that fluid, you can take a Q-tip and you rub it on a microscope slide and you let it dry for 10 minutes. Then you look under a microscope slide and you are looking for ferning. It actually looks like the leaves of a fern plant if it's amniotic fluid. And then you can use the dye paper test, that pH nitrazine paper that you can use. You probably learned about it with potentially checking like pH gastric contents. You can put the fluid on there, and if it turns blue, then that is the appropriate pH of amniotic fluid. However, anything can turn that blue, so that's really not a good marker. The pooling and the ferning are much better markers for a speculum test, but that is what the provider is checking for. So what do we do if somebody's water breaks early? Sometimes their water breaks and then they'll start contracting. If their water is broken and they're preterm, we are not going to prevent them from going into labor if they're going into labor. We're not going to keep somebody who is preterm, whose water is broken, going into labor from going into labor. We're not going to give them those tocolytic medications that we just talked about because they're now at risk for infection. So if their body's going into labor, we're going to let them labor. If they're not going into labor, if they're not contracting, then we're going to monitor them. We're going to monitor the baby. They're going to get admitted to the hospital. They're going to be on labor and delivery for a while. And then they'll typically move to an antepartum unit. They're going to have, in the initial, they'll have continuous fetal monitoring. And then once they move to antepartum, they'll have daily fetal monitoring, sometimes twice a day. They will get antibiotics. They'll get 2 days of IV antibiotics, and then typically they'll switch to oral for the remainder for a total of 7 days to prevent any infection. They will get steroids. They will get that betamethasone injection, but they don't need the medications, the tocolytics, because they're not contracting. And if they are contracting, we are not going to hold on their labor to give them betamethasone. We'll monitor for infection. They're going to need frequent temperature monitoring, typically every 4 hours if they're in the hospital. I have seen these patients go home. It is very rare, but if they're stable in the hospital, and they live close, they could potentially go home. And if they go home, they're going to typically have to measure their, temperature twice a day at home. Sometimes in the hospital, they will actually measure their temperature more often, every 2 hours. It'll really depend on hospital policy. And if they're in the hospital, they'll have a daily CBC. 99.9% of the time, these people will be in the hospital because at any minute they could unfortunately develop an infection or fetal distress could occur. And remember, we are, we're encouraging hydration on them, we're doing NSTs on them, but they will keep leaking. Once their water breaks, that bag of water is open, so they will keep leaking. So that is something to be mindful of. But if they have increased leakage, if they have a change in the color of leakage, if they have an odor or fever, then that's something that we need to notify the provider about. And then premature rupture of membranes, PROM versus PPROM. PPROM is premature or preterm. Premature rupture of membranes is when somebody ruptures their membranes at term, but it's before labor starts. And so for those individuals, we can typically see if labor will start on its own. Oftentimes you may be able to give them up to 24 hours to see if labor starts on its own. And if it doesn't, have them come in to be induced. But sometimes some providers, depending on what's going on, if their water breaks, they will have them come in and be induced right away. So, but that is the term for someone whose water breaks before they go into labor and they are at term. Okay, chorioamnionitis. So chorioamnionitis is a bacterial infection of the amniotic cavity, and this can come from premature rupture of the membranes. It can come from a vaginitis, which is a vaginal infection. It can come from an amniocentesis, the procedure where you stick into the abdomen like we talked about. It could come from any kind of intrauterine procedure. Typically, what are they going to have? They're going to have uterine tenderness. They're going to have painful contractions. They're going to have a fever. Typically, the pregnant person will have tachycardia, and often if they have tachycardia and a fever, the baby's going to have tachycardia. There will usually be a foul odor to the amniotic fluid. So this is what we're trying to prevent when somebody's water breaks. This is why we watch them so closely. We're not doing vaginal exams. We do everything sterile if we need to do something. We're monitoring their vital signs. We're monitoring the baby's fetal heart rate. We're monitoring uterine tenderness and contractions. We are giving them antibiotics. And then typically after the baby's born, they will do some kind of cultures on the baby. Typically like a blood culture on the baby, just to make sure that the baby has not developed any kind of sepsis or anything. If somebody develops this, they will induce them if they're not in labor already. So they will give them like an oxytocin to get them to contract. And then if somebody develops this in labor, which can happen from multiple vaginal exams, their water being broken for a prolonged amount of time. Remember, we said 24 hours really starts to make us uncomfortable because they're at higher risk for infection. At 18, we start to get nervous. So if their water has been broken for a long time, this can put them at risk. If they're not on oxytocin, we're going to put them on oxytocin so that we can get them to deliver. Okay, hypertensive disorders in pregnancy. So we have a couple different hypertensive disorders in pregnancy. So gestational hypertension is hypertension first diagnosed after 20 weeks of pregnancy. So these are people who have hypertension, but they have no abnormal lab values. And that'll make sense when we start to talk about preeclampsia and HELLP syndrome. So remember, in our pregnant people, hypertension is considered a systolic of 140 or higher, or it does not need to be both, a diastolic of 90 or higher. And this is 2 occasions 4 hours apart. They don't have protein, they have no abnormal labs, they have no signs or symptoms of preeclampsia. These are just people who have hypertension in pregnancy. This can turn into preeclampsia, so we need to be mindful of that. Preeclampsia. So preeclampsia, and if anyone's using an older textbook, this is something that's very blatantly different now. It used to be called mild and severe preeclampsia. It's now preeclampsia with or without severe features. So preeclampsia with severe features, and then preeclampsia without severe features. I will talk about them separately on the next page. We have eclampsia. So with preeclampsia, what we're trying to prevent is eclampsia. So this is the new onset of tonic-clonic seizures in the absence of another cause with hypertension. So this is not somebody who's having seizures because they have a seizure disorder. This is somebody who's having seizures because of preeclampsia. And so in preeclampsia, this is what we are trying to avoid. We are trying to avoid eclampsia, which is progressing to seizures, which is why we give medications to prevent that. And then HELP syndrome. HELP syndrome is, it stands for hemolysis, elevated liver enzymes, and low platelets. There is some thought that this is a severe form of preeclampsia versus some people who think that this is actually a separate disorder. And I'm more in the school of thought that this is a separate disorder than a severe form of preeclampsia, and we'll talk about that. Okay, so preeclampsia without severe features. So this is somebody who has a blood pressure of 140 or higher systolically and or a diastolic of 90 or higher on 2 events or more, 4 hours apart, with significant proteinuria. So this is somebody who has elevated blood pressure, and we have done a workup to assess for preeclampsia, and they have significant proteinuria. So significant proteinuria is defined as 300 milligrams in a 24-hour urine, or 0.3 milligrams on a protein creatinine ratio, which is when they just pee into a cup and you do a protein and a creatinine and you do a calculation. And if it's 0.3 or higher, that is thought to equal 300 milligrams or more in a 24-hour urine. So in somebody with preeclampsia without severe features, that is what they have. They have elevated blood pressure and significant proteinuria. They have no other lab abnormalities or symptoms. So what labs are we doing in somebody who has preeclampsia or that we're concerned that they have preeclampsia? We're assessing their blood pressure. We're getting a urine. So typically we're going to do a UA and we're going to order that protein and creatinine that I talked about. We will also typically do a 24-hour urine, but because that takes 24 hours, we need a faster answer. We're going to do a CBC because we need to know what their hematocrit and their platelets are. We're going to do LFTs because we want to know what their ALT and AST are. And we're typically going to do a BMP because we want to know what their creatinine is, okay? So all of those things. So in somebody who has preeclampsia with severe features, there's a couple different ways that somebody can have preeclampsia with severe features. They can have severe range blood pressures, which is systolic of 160 or higher and or a diastolic of 110 or higher with significant proteinuria. And again, significant proteinuria is 300 milligrams or more in a 24-hour or 0.3 in that protein creatinine ratio. And the severe blood pressures can be confirmed within minutes. You don't need to wait 4 hours for a severe blood pressure because those people are at risk for stroking. So we're not going to sit around and wait for somebody to have a severe, for someone to have multiple severe range blood pressures over hours. Or it can be somebody who has a systolic blood pressure of 140 or higher and or a diastolic of 90. It should be 90 or higher and so this could be severe range or not, with a headache unresponsive to a medication. So this is somebody that they've had, Tylenol, maybe they've had Benadryl, they've had maybe magnesium. There are different management options for headaches in pregnancy, and it's not responding to any of them. Vision changes. They're having double vision, blurry vision, spots in their vision, or they're having epigastric pain, typically up here in that right upper quadrant. Unresponsive to pain medication or heartburn medication. Their platelets could be under 100,000. Their ALT and AST are twice that of normal. Their creatinine is 1.1 or twice their baseline, or they have pulmonary edema. They do not have to have all of these. They just have to have one of them along with the blood pressure to be considered preeclampsia with severe features. And so that's the difference. And somebody who does not have severe features, they have a blood pressure that's not in the severe range and they just have protein. To have severe features, they either have a blood pressure in the severe range with a sign and symptom or proteinuria, or they have a blood pressure over 140 or diastolically over 90 with one of the signs and symptoms of preeclampsia. So what happens? So we know that, we don't totally know what causes preeclampsia. We know that it has something to do with the way the placenta develops and the way that the arteries develop in pregnancy. And there's a resistance. Typically in a normal pregnancy, the arteries that attach the placenta are wide open and they cause normal blood flow. And in preeclampsia, for some reason, these arteries that the placenta is attached to when it forms and implants, they're not as wide open as they should be. And so there's increased resistance. And this increased resistance causes vasoconstriction and increased blood pressure. It can cause vasospasms in the kidneys, causing increased protein and increased creatinine. And it can also cause edema. Now, edema is no longer a diagnostic criteria for preeclampsia, but it does make us suspicious if somebody has high blood pressure and edema that they could be brewing some preeclampsia. So what are our risk factors for preeclampsia? Someone younger than 19 or older than 40, if this is their first pregnancy, if they're morbidly obese, if they have multiples, if they have chronic renal disease because we know their kidneys do not work well already, if they have chronic hypertension because they already have blood pressure issues, and somebody can have hypertension prior to pregnancy and it can progress to preeclampsia. Family history of preeclampsia, diabetes, gestational diabetes, rheumatoid arthritis, and lupus, because those people are also at increased risk for preeclampsia. And so symptoms, we already talked about the symptoms, but what are some physical findings that are not diagnostic, but make us suspicious? Risk reflexes. So remember, normal reflexes are 2+, but in somebody who has preeclampsia, because, their cerebral factors are a little bit heightened. They have a headache. They're at higher risk for seizures. They typically have faster reflexes. So these are people who may have +3 or +4 reflexes. Decreased breath sounds because we're worried about the risk of pulmonary edema, facial edema. Sometimes they have lower extremity edema, hand edema, and clonus. And so I don't know if you remember clonus from health assessment, but clonus is when you take somebody's foot and pull it back, it normally goes like this. But in preeclampsia, if someone has clonus, it's going to go beat, beat, beat. It's going to kind of beat. And that is not normal. And so that's something that we assess for. And so we already talked about the lab tests, the urine protein, the liver function tests. You can just order liver function tests, but the tests that we're specifically thinking about are ALT and AST. LDH we do not use for preeclampsia, but it helps us rule out preeclampsia versus HELLP syndrome, and I'll talk about that. Creatinine, and then our CBC. So brisk reflexes, headache, clonus. This makes us think about cerebral edema and irritability of the neurological system. And so that they all kind of go hand in hand. And even though clonus and brisk reflexes are not diagnostic, and headache is, they do typically go hand in hand. So how do we treat these patients? Antihypertensive meds. So typically if they are near severe range, so, getting near the 160 and or 110 diastolically, we're going to treat them. We're typically going to use an IV medication like a labetalol or a hydralazine. And then once we get their blood pressure controlled, we're going to get them on an oral regimen. These people are going to get, if they have preeclampsia with severe features, they are going to get magnesium sulfate. Magnesium is going to help prevent seizures. It's going to help prevent eclampsia, okay? It's going to help lower that seizure threshold. These people are typically going to get 4 to 6 gram bolus and then 2 grams an hour. It also is a vasodilator, decreases peripheral resistance. So like I said, prevents seizures, but also decreases blood pressure. So works hand in hand. If they're also getting a blood pressure medication, we have to watch it. If they're under 34 weeks, they're also going to get betamethasone, and then we're going to deliver them. When somebody is diagnosed with preeclampsia with severe features, we are delivering them. We're not keeping them pregnant. So what are we going to do as the nurse? We're going to monitor them closely. They're going to be on continuous fetal monitoring. We're going to monitor them for signs of magnesium toxicity, which I will talk about next. And then client education. They're going to be NPO. They're going to be on bed rest. They're not going to have a lot of visitors. They're going to be in a calm, quiet room. You're going to have to be checking on them every single hour. So you typically will be one-on-one-ing this patient. If they have preeclampsia without severe features, they typically will be monitored. And then once they get to 37 weeks, as long as they do not turn into preeclampsia with severe features, they will be delivered. If they're after 37 weeks and they're diagnosed with preeclampsia without severe features, then they will be delivered anytime after 37 weeks. But if they have preeclampsia with severe features, we are delivering them and putting them on magnesium because we are preventing eclampsia. So what are our signs of magnesium toxicity? So like I said, we are doing magnesium checks every 1 hour. We're checking their vital signs, their respiratory rate, their O2, their blood pressure, their heart rate. We're checking their reflexes every hour. If they have absent reflexes, that is a sign of magnesium toxicity. If they have hypotension, that's a sign of magnesium toxicity. If they have respiratory depression, if their respiratory rate is under 12, that is a sign of magnesium toxicity. If they have decreased urine output, if it's less than 30 cc's per hour, then that is a sign of magnesium toxicity. If they have shortness of breath, that is a sign of magnesium toxicity. If they have chest pain, that's a sign of magnesium toxicity. If they have confusion, slurred speech, difficult to arouse, that is a sign of magnesium toxicity. So we're checking all these things. We're checking their vital signs. We're checking their urine output. We're checking their clonus, they're checking their reflexes, we're checking their urine output, we're listening to their lungs, we're assessing all of these things. And if we have any concerns of signs for magnesium toxicity, we are stopping their magnesium and we are giving the antidote to magnesium. The antidote is calcium gluconate. We are then also drawing a magnesium level. Typically, patients who are on magnesium have these orders. You will let the provider know, but you are still doing these things because we do not want them to become really not mag toxic and become unresponsive. So this is something that you are checking every single hour on these patients. And this is whether they're on magnesium for preterm labor or magnesium for preeclampsia, okay? Okay, help. Any questions about preeclampsia or anything I've said so far? Okay, HELLP syndrome. So HELLP syndrome, like I said, some people think that this is, potentially a severe form of preeclampsia. I think that this is a little bit different than preeclampsia. Remember, I tell you what HELLP syndrome stands for a couple slides away. The difference is they can look very similar, and so I'm going to talk about it. So HELLP syndrome, they can have epigastric pain or right upper quadrant pain, severe edema. They can have symptoms of preeclampsia. They can have the same symptoms of preeclampsia. They can have nausea and vomiting, general malaise. On labs, so sometimes the way to tell the difference between this is their LDH. So these patients are having hemolysis of their red blood cells. So typically in preeclampsia, those people are a little more intravascularly dry. And so you're going to see elevated hemoglobin and hematocrit. And these patients, they have hemolysis. So you're going to see low hemoglobin and hematocrit because their body is attacking their red blood cells. So one of the markers of hemolysis is an LDH. And so an LDH of 600 or more is a diagnostic criteria for HELLP syndrome, which would not happen in preeclampsia. In preeclampsia, their LDH is going to be normal. These patients will have thrombocytopenia. That is one of the characteristics of this, low platelets. So they will have platelets below 100,000, and then they will have elevated liver enzymes. So that's what it stands for, hemolysis, elevated liver, low platelets. So they will have the ALT and the AST will be greater than 2 times the normal. And so you can see it sounds a lot like preeclampsia, but the difference is not every patient with HELLP syndrome has elevated blood pressure. And so sometimes they will have these symptoms, but their blood pressure will be normal. But you have to think, could they potentially have HELLP syndrome? This is an emergency. They're going to be in the ICU. These patients can still be at risk for seizures. And to be honest with you, majority of the time they do have elevated blood pressure. So they are going to get magnesium. So these patients are going to have the same monitoring that we just talked about. We need to reverse their thrombocytopenia because they can bleed, fresh frozen plasma, platelets, and these people are going to be delivered. And so what are we going to do? We're going to monitor their vital signs. They're again going to be in a quiet room. You want to be careful avoiding really palpating their abdomen because they can get these liver hematomas and they can actually like burst. And then these people, if they have a C-section, may be under general because of the low platelets, depending on how low their platelets are. Okay, Polly, so hydramnios, we've talked about this a little bit already. So sorry guys, hold on. Sorry, mailman. So oligohydramnios, this is low amniotic fluid. So with amniotic fluid, we can do something called an amniotic fluid index, which can give us a marker of roughly how much amniotic fluid is in there. So in oligohydramnios, there's not enough amniotic fluid. And so typically their AFI or amniotic fluid index is going to be 5 or less. Typically this may be because there is either a bladder disorder or a kidney disorder that the fetus is not properly forming urine. When there's not enough amniotic fluid, it could cause the lungs to have trouble developing properly. So we suspect this if a baby's measuring small. Is the baby measuring small, or is because there's not a lot of amniotic fluid when we're doing our abdominal exams? For polyhydramnios, that's when the amniotic fluid index is 24 or higher, so it's a lot of amniotic fluid. The big risk with this is the baby can flip a lot. It has a lot of extra room, so it can flip back and forth. It could be breech, it could be transverse. They could have premature rupture of membranes, and their cord could prolapse. And we'll talk about cord prolapse in a couple of weeks, but the cord can slip down, like we've talked about, in front of the baby's head because there's just a lot of fluid there. And signs and symptoms of this is they typically have a larger uterus. And so you wonder, is it amniotic fluid or is it the size of the baby? Okay, fetal demise. So this is death of a fetus after 20 weeks of gestation or before birth. So also typically called stillbirth. So what are things that could potentially make us concerned for fetal demise? A patient coming in complaining of decreased fetal movement or not feeling their baby move, not being able to find fetal heart tones with the monitor when you're putting them on their non-stress test, lack of fetal growth, so the baby is not growing on exam, or the fundal height has actually gotten smaller. And so when there is concern for fetal demise and the nurse cannot find the heartbeat when you put them on the monitor, you're going to call the provider. The provider is going to come do an ultrasound, and 2 providers will verify that there's no heartbeat if they're confirming a fetal demise. You always have 2 providers look when diagnosing a fetal demise. And so what is the nurse going to do? The nurse is going to provide supportive care. They're going to assist with delivery. They're going to support the patient and what they want. Do they want to hold the baby? Do they not want to hold the baby? Do they want photos of the baby? What do they want? The nurse is there to support them. They're going to call chaplain if they want chaplain. Typically, if there's been a loss, there will be a little, there'll typically be some kind of marker on their door so that people know that this family has experienced a loss, to be mindful when you're coming in and speaking to them. And then depending on the result of the loss, there could be an autopsy required versus offering an autopsy versus helping with any kind of, postmortem care of the baby after the family sees the baby if they want to. Memory boxes, every hospital does something a little bit different, but that's the nurse's role to help support the family in what they want. And then post-term pregnancy. So this is a pregnancy 42 weeks and beyond. So what we worry about in a post-term pregnancy is that the placenta is going to give out, that we're going to have placental insufficiency. The longer someone stays pregnant, the higher the risk that is of the baby getting larger, macrosomia. There is a risk for stillbirth, especially if the placenta stops working properly, and meconium aspiration. So we talked about this, that first stool in utero. If that happens, there is a risk of the baby aspirating it and ending up with an infection. So it's really important that before we call a post-term pregnancy, we have good dating and we know that they are, that their dating is accurate and they really are post-term. Sometimes late in that pregnancy, in the 3rd trimester, ultrasounds could be 3 weeks off. And so it may not, be accurate. So you want to know, do they have good dating? In the United States, our recommendation now is if somebody is not delivered by 41 weeks, we really should be doing an induction of labor, absolutely inducing them by 42 weeks, just because of the risk of fetal demise. And if somebody goes between 41 and 42 weeks, they need an NST and a BPP during that time period to monitor for fetal well-being. And if there's any signs of fetal distress, recommending delivery. Okay, knowledge check. A pregnant client at 37 weeks gestation comes into the emergency room with heavy bleeding and begins to show signs of hypovolemic shock. As an intervention, what would you do? Who wants to guess? Or who wants to answer? Nobody?
B.
Perform a vaginal exam. Do we think B? What are we going to do if somebody's bleeding? Are we going to do a vaginal exam if somebody's bleeding?
That assessment is the first thing the nurse has to do.
But what did I say? If somebody's bleeding, are we doing a vaginal exam? What do we need to know first?
How is
Placenta is intact?
We need to know where the placenta is. If somebody comes in bleeding, we need to know where the placenta is, right? Because do we want to do a vaginal exam and we don't know where their placenta is and we potentially stick our fingers through the placenta?
No.
No.
Oh, definitely not. So think about this. This patient is in hypovolemic shock. What are we going to do? So are we going to
Probably gain access.
are we going to put the client flat on their back? Do we ever put a pregnant person flat on their back?
No.
Are we going to do a vaginal exam? We just talked about that. No.
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 What about an IV access with a 27 gauge needle? Is that a big needle or a small needle?
Small needle.
Small.
Small needle. Are we going to withhold oral fluid?
Most likely.
Yeah, why?
Because the person might be going to C-section or something.
Exactly. And we don't want them to aspirate. Exactly. Perfect. Okay. A client whose membranes ruptured is discharged to home care. Which of the following points would you most likely include in their teaching plan?
A.
Mhm.
Yep, exactly. So having them monitor their temperature twice a day. So like I said, it's rare that someone will go home if their water's broken, but we are having them monitor their temperature because we're looking for infection. And if their water broke, we're not putting anything in the vagina. They're not having intercourse. They're on pelvic rest, okay? We're not putting anything in the vagina, so we're not doing vaginal exams unless we absolutely have to. But they are monitoring their temperature. After reporting to the unit, you are assigned the following patients. Which of the patients should be evaluated first?
C. C.
C, great. Yes, because what does that make us worried about? A ruptured ectopic. A client's glucose challenge test is 145 at 1 hour post-glucola. Which of the following physician orders is appropriate?
They need more tests now to confirm.
What'd you say?
No, I was thinking that the more tests will be needed to confirm something.
Yeah, more. So what do you think more tests? So what do you think the answer is?
I go with D.
D, yeah. So remember, the GCT, the glucose challenge test, or sometimes called the glucola, is the screening test. And what did I say? No matter what is our cutoff? The absolute last cutoff is what?
39.
Yes. So anything 140 or above is too high. So if they're 145, it's too high. So we need to send them for a diagnostic test. And that's a 3-hour glucose tolerance test. That's what that's called, to help diagnose if they have diabetes. Okay, hold on. Let me stop my sharing. Okay, let me see if I missed anything. Great. Okay, so what questions does everybody have? I will post this. It is recorded. I do want to note on exam 3, there is going to be math on how to calculate magnesium calculations. So I've posted a video and magnesium practice problems. If you follow that method, it's very easy to calculate. I'm not collecting the practice problems, but I put them there for you all to practice for the exam. And it's going to be very similar to when you learn how to calculate Pitocin problems before our exam 4. So please take a look at that. I will post this after class, and that's it. If no one has any questions, I'm going to let you all go. Do you have a psych exam today?
Yes.
Okay.
Yes.
I